The sensation of nausea makes us feel pretty miserable, doesn't it? For patients living with cancer or advanced organ illnesses, and in the context of palliative care, nausea is one of the most common and distressing symptoms we encounter. In part 1 of the series, I'm going to break down the different causes of nausea and explain some of the physiology behind why it happens. Because when we understand why nausea occurs, we're much better equipped to treat it. And the treatments start to make a whole lot more sense. Let's talk about it. Welcome to Palliative Care Explained, a channel aimed at answering your questions about palliative care. My name is Dr. Jonathan Wong, and I'm a palliative care doctor based out of Winnipeg, Canada. Please see the welcome video of this channel for my declaration that I do not have any conflicts of interest or any financial sponsors, and for the medical legal disclaimer statements. If I were to ask you to describe nausea, or to give me a definition of nausea, what would you say? It's pretty tricky, isn't it? Nausea is medically defined as an unpleasant sensation associated with an urge to vomit. But unpleasant sensation is still pretty vague. So when asked to put nausea into words, many people would say queasiness, seasick, or use phrases such as being sick to the stomach. As an interesting aside, the root of the word nausea comes from the Greek word for ship. And just looking at those waves makes me seasick. Some people may also experience associated sensations, such as having cold sweats, butterflies in your stomach, or feeling like your stomach is in your throat. While others may describe feeling pale in the face, having a desire to remain still, or a need for fresh air. And this is why nausea is so difficult to define. It is experienced in many different ways. And to further complicate the definition of nausea, despite being associated with the urge to vomit, nausea is not always followed by vomiting, and vomiting can occur without preceding nausea. The symptom of nausea probably developed or evolved from the human body's attempt to provide a warning of impending threat or danger. That perceived threat could be from outside or inside the body, and could range from being completely benign to something actually harmful. But in the moment, the experience of nausea does not always narrow down what that threat actually is. And ironically, despite serving as a warning sign, prolonged nausea often leads to medical problems such as dehydration and malnutrition. So what causes nausea? Rather than simply providing you with a list of common causes, it would be more useful for me to group them into different categories or sources and talk about some of the physiology behind it. First though, we need to talk about an area in the brainstem often referred to as the vomiting center. More formally, is called the Nucleus Tractus Solitarius, or NTS. This collection of neurons and receptors receives signals from different parts of your body. As you will soon see, there are several different neurotransmitters that can activate the vomiting center. By being aware of their role, understanding how the treatments work will become much easier. So let's dive in and talk about the 6 main sources that can activate the vomiting center. Let's start with the vestibular system. Located within the inner ear, the vestibular system helps us to maintain our balance, helps with spatial orientation, and has a role in coordinating our eye movements. If your vestibular system perceives visual or inner ear signals that are out of the norm, it sends chemical signals to activate the vomiting center. In this pathway, the neurotransmitters involved are predominantly acetylcholine and histamine. Common examples of vestibular system associated nausea include motion sickness, such as traveling on boats or airplanes, the dizziness we experience by putting on someone else's prescription glasses, or when we are watching very fast-moving pictures on a big movie screen. There is also a very long list of medications that can disturb the vestibular system, and this includes the use of antibiotics, antidepressants, anti-seizure medications, sedatives, and many chemotherapy agents. The next source, we have the gastrointestinal tract. This includes anything that affects our mouth all the way down to our anus. So the list of potential causes is quite long. The upper GI tract includes the mouth down to the first part of the intestine. Let's start with inside the mouth. In the context of palliative care, common causes of nausea include a dry mouth, mechanical difficulties with swallowing, which can induce a gag reflex, gum and mucosal irritation, such as chemotherapy-induced mouth sores, and fungal infections, such as thrush. These fungal infections can also spread into the esophagus. Within the esophagus, we frequently see inflammation caused by chronic acid reflux, and in many people, reflux can cause esophageal spasms, resulting in pain and nausea. In the stomach, slow emptying or gastric stasis and physical abnormalities in the junction between the stomach and the first part of the small intestine can lead to a full or bloated stomach, feelings of regurgitation, and hiccups, which themselves can induce a gag reflex or sensation of retching. The lower GI tract includes the small intestines, the large intestines, and ends at the anus. Here, nausea can be caused by the intestines moving too quickly or too slowly. A common example of intestines moving too quickly is colonic infections, such as food poisoning. There are also inflammatory conditions, such as Crohn's colitis, endocrine conditions, such as hyperthyroidism, and dumping syndromes from a variety of different causes. In a palliative care context, we often see slow-moving intestines in the form of constipation, as well as intestinal blockages and obstructions due to the presence of cancer. We also see bowels that move in a less coordinated way, caused by autonomic nervous system dysfunction, such as that seen in advanced Parkinson's disease and ALS. Looking outside of the intestinal walls, the presence of extra fluid in the abdomen, such as ascites, or the presence of adjacent cancers pushing into the bowel wall, can result in impaired bowel motility, resulting in the sensation of nausea. How do our intestines communicate with our brain? It's a fascinating and complicated system. Your gut has its own enteric nervous system, almost like a second brain, which can send signals up to the central nervous system. And this in turn can activate the vomiting center predominantly through neurotransmitters such as dopamine and serotonin. Next up, let's talk about the organs inside our abdomen and their linings. Our organs do not tolerate being stretched. And when they are, mechanoreceptors send signals to the central nervous system, which in turn activate the vomiting center predominantly through the neurotransmitters serotonin, acetylcholine, and substance P. Now we've heard of serotonin and acetylcholine earlier, but substance P and its receptor NK1 has become a target for a newer generation of medical treatments for nausea. This overlaps with the stretching of the gastrointestinal tract, as we just discussed, but it extends to other intra-abdominal organs too. For example, stretching of the liver lining from illnesses such as hepatitis or cancers affecting the liver often results in sensations of nausea in addition to pain. Looking at a nearby organ, the stretching of the kidney lining from illnesses such as infections of the kidney tissue, kidney stones, or hydronephrosis from urinary obstruction often results in severe nausea. The next source to talk about are signals coming from the chemoreceptor trigger zone. Located in our brainstem right beside the vomiting center, this zone senses and responds to chemical abnormalities in the bloodstream, such as medication toxicities and metabolic disturbances. If this zone detects chemical levels outside of the programmed norm, it activates the vomiting center predominantly through the neurotransmitters dopamine, serotonin, and substance P. In the palliative care context, the nausea induced by chemotherapy, as well as the nausea experienced when starting or increasing the dosage of opioid analgesics, is triggered through this chemoreceptor trigger zone. This zone also responds to electrolyte abnormalities, such as high calcium levels, which can be seen with a number of different cancers, as well as metabolic abnormalities, such as the buildup of waste products from kidney and liver failure, commonly seen towards the end of life. Next up, we have causes of nausea that come from abnormalities in the brain tissue. Common causes can include brain injury syndromes, such as concussions, migraine headache syndromes, and infections, such as meningitis. In the palliative care context, causes can include the presence of tumors or bleeding inside the brain, and this can lead to increased pressures inside our brain. Why would that increase the pressure inside our brain? Our skull acts like a rigid helmet that doesn't expand. So let's pretend this balloon is the brain. So anything that pushes on the brain or causes the brain to swell or expand can increase the intracranial pressure. The brain tissue has nowhere to go, and this often leads to nausea and vomiting. Narrowing down the most responsible neurotransmitters in these cases is more difficult, as it depends on which part of the brain is most affected. But the main neurotransmitters involved with activating the vomiting center are similar to the ones we have already described. Finally, we have causes of nausea that come from the thinking and processing parts of our brain. These cortical centers are responsible for how we experience things, such as sights and smells. Importantly, these centers are also closely linked with the emotional and memory centers in our brain. It's very complex how our brain integrates previously formed memories and emotions with current ones. The brain can activate the vomiting center through neurotransmitters such as serotonin, GABA, or gamma-aminobutyric acid, and histamine. But given the complexity, there are likely multiple pathways simultaneously involved. The nausea brought on by fear is most likely mediated by this pathway. And I think we can all appreciate the scenarios where nervousness or a sudden visual experience of something gory can result in nausea and vomiting. Nausea can also be induced by intense worry or anxiety, and this is thought to be caused by the release of stress hormones such as adrenaline and cortisol that are part of our brain's fight or flight response. On the topic of stress and anxiety, let's talk about a response called anticipatory nausea. What is anticipatory nausea, and why does it happen? Anticipatory nausea is a conditioned stress response to previously experienced nausea. This is commonly associated with chemotherapy-induced nausea. Previous memories, including sights, smells, and sounds, can leave a very strong imprint, conditioning the brain to rerun that symptomatic experience in anticipation of the next event. In summary, nausea can have many different medical causes. It may result from an emergent underlying issue, or from a perceived threat as processed by the brain. In this video, we discussed how different parts of the body can activate the vomiting center through the use of different neurotransmitters. The vomiting center can be activated by signals from the vestibular system, from the gastrointestinal tract, from mechanoreceptors that monitor organ stretching, from the chemoreceptor trigger zone that monitors the blood, from structural brain inputs, and from the memory and emotional processing centers of the brain. When we are better able to identify the different causes of nausea, we become better able to provide relief with the appropriate treatments and medications. Thank you very much for watching this video. I hope to see you in part 2, where we will break down the treatments for each of these different causes of nausea.